Hi, I'm Dr. Ted Delbridge, Executive Director at MEMS. Each year around this time, we present for you updates to the protocols for Maryland's emergency medical services. It's surely not because the science of EMS changes only once a year or at this time of year. It's our effort to be efficient with your use of time. So in advance, thank you for the time you'll now spend to receive these important updates, and thank you for what you do each and every day.
Hello, and welcome to the 2022 Maryland EMS Protocol Update. I'm Dr. Tim Chismar, State EMS Medical Director. First, please allow me to offer my sincerest gratitude to all of our EMS clinicians who have cared for our patients, especially over the past 2 years. While many of our usual activities have been paused during the COVID-19 pandemic, the Protocol Review Committee has been hard at work. Based on the latest scientific evidence, I'm pleased to present you with a number of protocol additions, revisions, and even a few deletions. You should know our protocol changes come from a multidisciplined team of EMTs, CRTs, paramedics, physicians, nurses, and other healthcare professionals. We are constantly reevaluating our protocols to provide you with the clearest, updated guidance on patient care. In a few minutes, you will hear about our new protocols from EMS clinicians and educators from across the state. But first, let me cover a few brief updates. Many of you are already familiar with the direct-to-triage protocol. This was approved by the EMS board during mid-2021 for immediate implementation. Most jurisdictions in the state have adopted this optional supplemental protocol. If you're unsure about your county or city status, please check with your leadership. The direct-to-triage protocol enables EMS clinicians to select patients who are stable for placement in queue for ED triage. Importantly, a verbal and written report should be given to the receiving triage or waiting room nurse. A second addition is the technique of left lateral uterine displacement for pregnant patients presenting with shock, hypoperfusion, or cardiac arrest. This concept is relatively straightforward and has been recommended by the American Heart Association. As the fetus grows larger over time, the uterus can compress the aorta and vena cava when a pregnant patient is in the supine position. This, in turn, can lead to a decrease in blood return to the heart and cause hypotension or low blood pressure. By applying continuous manual displacement of the uterus to the pregnant mother's left side, the pressure on the aorta and vena cava is relieved. For pregnant patients with the uterus palpable above the umbilicus, this allows for an increase in venous return and cardiac output. One final change I'll mention is actually a deletion. Based upon recent literature, including the Targeted Temperature Management 2 trial, otherwise called TTM2, the Induced Neuroprotective Hypothermia protocol has been removed. In TTM2, investigators randomized 1,850 adult patients with coma after out-of-hospital cardiac arrest into 2 treatment arms. The first group received hypothermia to 33 degrees Celsius, followed by controlled rewarming, while the second group was treated by maintaining normothermia with early treatment of fever defined as 37.8 Celsius or greater. The primary outcome was death from any cause at 6 months. And at 6 months, 50% of the hypothermia group and 48% of the normothermia group had died. In short, there was no significant difference between the 2 groups. Importantly, there was also no difference in the degree of neurologic disability among the survivors in the 2 groups. The hypothermia group also experienced a greater incidence of arrhythmias. Targeted temperature management, particularly the prevention of fever, may still play a role later in the patient's hospital or ICU level care. However, for EMS, the evidence shows that we are most effective when we focus on high-quality CPR and defibrillation. Next, I would like to transition from the new protocols and touch on an important topic which may be overlooked, and that is patient refusals of treatment or transport. Generally speaking, non-transported patients are at higher risk for adverse outcomes. When you're confronted with these situations, please refer to the patient-initiated refusal of EMS protocol in the procedures section. This checklist will walk you through the steps. First, offer the patient or the potential patient an assessment and treatment. As you're speaking with the person, try to assess whether they have capacity to make medical decisions. Patients with capacity should be alert, oriented, and able to understand the risk and benefit of treatment and transport. If the patient is disoriented or lacks medical capacity, implied or emergency consent will apply, and the patient should be transported for further medical evaluation. We need to be cautious to use the lowest level of chemical sedation or physical restraint necessary to effect a safe transport for the patient. For patients with capacity, next you should evaluate for abnormal vital signs, high-risk injuries, or medical illnesses. If these are present, consult with the nearest base station so that the physician can speak with you and the patient about the decision. And finally, please be sure to document refusals thoroughly, including the refusal checklist. Be specific with your narrative. You should include details of what was said during the encounter. Include statements and quotes as much as possible. The no patient found call disposition should be reserved for cases in which there is really no person with a medical complaint or evident illness or injury found at the scene. If you're speaking with and assessing someone, you should document it. For more information on this important topic, please check out Who is a Patient in EMS in the MIMS Online Training Center. Notably, we should not be suggesting refusal of care or transport unless it is in the context of the pandemic triage protocol. This tool will remain available in eMeds. It has undergone extensive study. When the checklist and decision support tool in eMeds are used, the risk of subsequent hospitalization within 24 hours was very low, approximately 5%. In closing, I hope that you will enjoy this year's update. And again, thank you for taking your time to learn about the new 2022 Maryland Medical Protocols for EMS. I am grateful for your continued commitment to the best possible care for our patients in Maryland.
EMS clinicians are always there to help their fellow Marylanders with medical and trauma-based emergencies, but doing so can sometimes take a toll on us. When the job or a difficult call affects us, who helps the helper? Fortunately, there are resources available throughout our state to help support the professional and personal well-being of Maryland's EMS clinicians.
Hello, I'm Victor Welzant, Director of Training for the International Critical Incident Stress Foundation, here with a few quick tips and reminders about stress and resilience. We all know that stress is a normal part of performing the important work of emergency services. Managing our stress reactions and building resilience helps us perform at our highest levels, stay healthy, and meet the challenges in our personal and professional lives head on. The good news is there are many things we can do to build resilience. Everyone is different, and there's no one way to do it. One of the most effective ways is to maintain our physical health through exercise, good nutrition, rest, and sleep. Knowing the warning signs of too much stress is also helpful. Supportive relationships are crucial to resilience, especially when under greater stress. Support is a core factor of resilience, so giving people in our lives time, energy, and caring is really important for our mental health. Doing things we enjoy is also a good way to balance the impact of stress. Hobbies, sports, and other activities that recharge our mental batteries help to balance our lives and make us feel good about ourselves, our relationships, and the work that we do. Relaxation and participation in activities such as yoga, meditation, and simply being outdoors are also good ways to build resilience.
Hello, my name is Courtney Shannon, and I am a paramedic lieutenant with Charles County Emergency Services. Camaraderie has always been a part of EMS. Although peer support has become a buzzword, the idea is fundamental to our profession. We have always had each other's backs and recommended services to one another. In recent years, many agencies have formed peer support teams and networks comprised of individuals who have basic training in behavioral health as it relates to working in this field. These colleagues take an often proactive, always confidential approach to recommending resources that understand who we are as clinicians. Sometimes they simply lend an empathetic ear for both on and off the job situations. Critical incident stress management can provide helpful intervention by talking through recent traumatic events. Like with peer support, CISM must be completely voluntary and should never be forced on anyone that doesn't feel comfortable talking. Confidentiality is of utmost importance to clinicians, and at times EAP services may provide the bridge to resources. To learn more about what your department has to offer, consider asking your chain of command. Again, if confidentiality is of utmost importance to you, consider calling the MarylandEMS helpline at 1-800-648-3001. Callers to the MarylandEMS number are connected with peer support and other resources in your area or surrounding jurisdictions. Should a member of your department be in crisis, please consider the National Suicide Prevention Hotline, 1-800-273-8255, or simply dial 211 and press 1. Suicide prevention resources are available 24/7 to anyone that is contemplating suicide. As EMS clinicians, we focus daily on our patients' needs and often overlook our own. Many resources are available throughout Maryland that can help you through the toughest times. Find out what is available in your area and ask for help. Remember, asking for help when you need it is a sign of strength, not weakness.
If you were at home and you or your child had a fever, how would you treat it? Odds are that acetaminophen, often referred to by the brand name Tylenol, would be high on your list of options. However, for EMS clinicians, ever since acetaminophen appeared in the Maryland formulary, it has only been authorized for treatment of mild to moderate pain, until now. Fever has not been an indication for its use in the out-of-hospital environment. This will change with the 2022 protocols. The other change that you will find in the use of acetaminophen is that the minimum age for its use has been lowered from 2 years of age to 3 months of age. Let's review the ALS and BLS pharmacology for acetaminophen, noting the changes in the 2022 protocols. Indications for administration of acetaminophen now includes patients 3 months of age and older with either mild to moderate discomfort, example 1 to 5 on the FACES scale, or fever documented by EMS as greater than or equal to 100.4 degrees Fahrenheit or 38 degrees Celsius. This is an important point. Acetaminophen should not be given for fever without obtaining an accurate temperature. Precautions for its use are: administration of acetaminophen for mild to moderate pain doesn't eliminate the need to transport the patient to a facility capable of conducting a comprehensive evaluation of the cause of pain and providing appropriate definitive treatment. A maximum size of 5 ml or 6 ml syringe must be used to measure doses. For the smaller doses, a 3 ml syringe is acceptable. Syringes larger than 6 ml do not have fine enough demarcations to make accurate measurements. With the exception of the change in the minimum age for administration, the contraindications are the same as in the past versions of the protocols and include head injury, hypertension, administration of acetaminophen or medications containing acetaminophen within the previous 4 hours. Remember, many common cold preparations contain acetaminophen. Inability to swallow or take medications by mouth, respiratory distress, persistent vomiting, known or suspected liver disease, including patients suspected of current alcohol ingestion, allergy to acetaminophen and patients less than 3 months of age. Acceptable preparation for administration remains unit dose preparation only. Specifically, clinicians may use either 160 milligrams in 5 ml liquid unit dose or 325 milligram pills or tablets for patients aged 13 years and older. Multi-dose bottles of liquid should not be used by EMS clinicians. Dosage of acetaminophen is based on age. Remember that for patients receiving less than a full unit dose of the liquid 160 milligrams in 5 ml preparation, a 3, 5, or 6 ml syringe must be used to measure the dose. Patients 3 months of age may be administered 1.25 ml, that is 40 milligrams, of the 160 milligrams in 5 ml liquid preparation. Patients 4 to 11 months of age may receive 2.5 ml, 80 milligrams, of the 160 milligrams in 5 ml liquid preparation. Patients 12 to 23 months of age may be administered 3.75 mLs, 120 milligrams of the 160 milligrams in 5 mLs liquid preparation. Patients 2 to 4 years old may be administered 1 unit dose of 160 milligrams in 5 mLs liquid preparation. Patients 5 to 12 years old may be administered 2 unit doses of 160 milligrams in 5 mLs liquid, a total of 320 milligrams in 10 mLs. And patients 13 years old and above may be administered either 4 unit doses of 160 milligrams in 5 mLs liquid, a total dose of 640 milligrams in 20 mLs, or 2 325 milligram pills or tablets for a total of 650 milligrams. Pills or tablets may be administered with sips of water as tolerated by the patient. In summary, the 2022 protocols lower the minimum age for administration to 3 months of age and expand the use of acetaminophen to include the treatment of fever documented by the clinician as above, 100.4 degrees Fahrenheit or 38 degrees Celsius. You are treating an 8-month-old male patient whose mother advises has been sick with a cough, decreased oral intake, and a fever for several days. The patient is alert but cranky with capillary refill of 2 seconds, respiratory rate of 36, and a pulse of 122. His skin is flushed and hot to touch. You obtain an auxiliary temperature of 103 degrees Fahrenheit. The patient's mother tells you she ran out of liquid acetaminophen yesterday and has given the patient no medication in the last 12 hours. You decide to administer acetaminophen to the patient. What dose and route administration should you choose? A, 2.5 mLs, 80 milligrams of 160 milligrams in 5 mLs liquid unit dose, measured using a 3, 5, or 6 ml syringe. B, 160 milligrams in 5 ml liquid unit dose, administered using a 5 or 6 ml syringe. A, that's right. The correct dose for an 8-month-old patient is 2.5 mLs, 80 milligrams, which should be drawn up from a 160 milligrams in 5 ml unit dose using a 5 or 6 ml syringe. Good job.
Can you remember your last critically ill patient? Did you want to hurry up and get him to the ambulance so you could get to the hospital quickly? If so, we want to draw your attention to the new critically unstable patient protocol. The General Patient Care Protocol has always prioritized the identification and treatment of life-threatening conditions. The Critically Unstable Patient Protocol clarifies the criteria that should be used in determining which patients are critically unstable and identifies the immediate actions to be taken by clinicians on scene. In other words, we want you to resuscitate before you start transport. Why is this important? And why should we emphasize this now? Recent studies have identified that unstable patients are at a high risk for post-arrival respiratory or cardiac arrest, PARCA. One study found that the proportion of PARCA patients significantly decreased from 12.1% of out-of-hospital cardiac arrest to 5.8% when immediate life threats are addressed within the first few minutes of arrival on scene. The data indicated that most PARCA occurred within 13 minutes of EMS arrival. It's critical that we intervene early and definitively with unstable patients. As a part of general patient care, the goal of the initial assessment has been to identify and correct life-threatening problems as they are encountered. The 2022 General Patient Care Protocol expands the initial assessment instructions by first defining the criteria for a critically unstable patient, then referring clinicians to the critically unstable patient protocol. A critically unstable patient is any patient who is in extremis or has an imminent risk for deterioration to cardiac arrest. These patients include those with a new onset of altered mental status, airway compromise, acute respiratory distress, signs of poor perfusion, or any patient judged by the clinician to be in extremis or at risk for deterioration to cardiac arrest. When a critically unstable patient is identified, the initial assessment then directs the clinician to stop all movement of the patient, do not initiate transport, and proceed to the critically unstable patient protocol immediately. The critically unstable patient protocol applies to adults, those 18 years of age or older, who were identified in the initial assessment as being in extremis or at risk for deteriorating to cardiac arrest at any point during their care. BLS care under this protocol begins with a reminder to cease all efforts at patient movement until the treatments in this protocol are complete. Clinicians should then obtain a complete patient assessment including pulse oximetry, consider the need for additional resources if available including multiple ALS clinicians, control life-threatening external hemorrhage, manage the patient's airway and ventilation as indicated and tolerated. This may include BVM ventilation with or without an OPA or NPA. Treat hypoxia and respiratory distress aggressively. In addition to the BLS care already outlined, ALS clinicians should initiate end-tidal CO2 monitoring, obtain a 12-lead EKG if it is appropriate for the patient's condition, obtain vascular access and support perfusion with IV fluids and vasopressors as indicated, address any other life threats noted on the physical exam. Once these steps have been completed, clinicians should continue general patient care and refer to specific protocols for the patient's condition, including transport to an appropriate facility. You are dispatched to the home of an 80-year-old female patient whose family called 911 because she is having difficulty breathing. On arrival, you are met at the door by the patient's daughter, who advises you that her mother is normally alert and independent. She has a history of CHF and COPD, and today she is having difficulty breathing and is becoming agitated and confused. You approach the patient, and on your initial assessment, you find her in obvious severe respiratory distress with rapid labored breathing. Her skin is pale, cool, and clammy, and she appears restless and confused. Your next action should include A. Transfer the patient into your ambulance and begin rapid transport to the nearest ED. All care can be performed en route to the ED. B. Obtain a complete assessment, including pulse oximetry, consider the need for additional resources, and treat the patient's hypoxia and respiratory distress aggressively with nebulized medications and/or CPAP on scene prior to initiating transport. That's exactly what we want you to do under the critically unstable patient protocol. Good job.
Have you ever encountered a patient with an implanted ventricular assist device, VAD, in the field? Would you know how to assess and treat them if you did? Ventricular assist devices used to be rare, and patients using the devices were often confined to the hospital while awaiting a heart transplant. However, VADs are becoming more common, and their use is expanding from the initial bridge to transplant treatment to also being a long-term solution for patients unable to receive a heart transplant. Because VAD patients are often being discharged home to live relatively normal lives, the chances of them having an EMS encounter are much greater now than in the past. As EMS clinicians, we need to be prepared to assess and care for these patients. To this end, the 2022 protocols introduce a new ventricular assist device, VAD protocol. Let's take a look at this new protocol. VAD devices include left, right, and biventricular assist devices, which are collectively referred to as VADs. The left ventricular assist device, or LVAD, is the most common type. The new 2022 VAD protocol has both BLS and ALS components and applies to adult patients who have a VAD and have symptoms of cardiovascular compromise or are in cardiac arrest. The first thing you need to know before you even start your assessment is that most VAD patients will not have a palpable pulse or detectable systolic or diastolic blood pressure due to the continuous nature of the pump. Don't get worried. We will discuss ways to assess perfusion in VAD patients. The preferred method of assessing perfusion in VAD patients is through the use of a Doppler and a manual blood pressure cuff. However, few EMS agencies carry a Doppler device, In the absence of Doppler capability, automated blood pressure cuffs may obtain a mean arterial blood pressure, or MAP, in some patients. The normal range for MAP is between 60 and 90 millimeters of mercury. EMS clinicians should also be aware that some VAD devices do create an artificial pulse that is activated every 2 seconds. This is to decrease the chances of clot formation on the motor. As with any patient assessment, we're going to start by assessing the patient's level of consciousness and vital signs. Remember to obtain that MAP with your automated BP cuff, if possible, because you won't be able to obtain a pulse rate and systolic or diastolic blood pressure. Check for breathing and assist ventilations if necessary. Assess for perfusion, checking skin color, skin temperature, capillary refill, MAP, and mental status. If the patient has adequate blood flow or perfusion, the skin color should be warm, capillary refill less than 2 seconds, and the patient should be alert. If the patient has altered mental status but has other signs of adequate perfusion, assess for other causes of altered mental status unrelated to the VAD. Check blood glucose and refer to the hyperglycemia protocol if appropriate. If you're concerned about possible overdose, refer to the overdose poisoning protocol. For patients with abnormal perfusion, if your patient is unresponsive, not breathing, has delayed capillary refill, and you are unable to obtain a MAP, initiate CPR with a manual chest compressions and provide ventilations per the cardiac arrest protocol. Chest compressions must be manual using hands only, as automated chest compression devices may increase the risk of VAD dislodgement. VAD patients can be defibrillated or have an AED applied without any changes or adjustment to their VAD device. Assess for alarms which can be audible or reported by the patient or bystanders. Listen for the pump sounds if you are listening for humming or whirling sounds over the chest. Assess the VAD. Check the power and connections from the controller to the batteries and driveline. Contact the patient's VAD coordinator using the phone number on the device and/or the patient's VAD-trained companion, who will likely be your best source of information for the need to return to the patient's tertiary care center. Change the VAD batteries and/or the controller if indicated. If the VAD batteries require changing, change only one battery at a time. So to change out the battery on the HeartMate 3 or the HeartMate 2, there's 2 ways to do it. One would be to just depress the button here and pull out and change out the battery. You can check to make sure that the battery is fully charged. The other way to change out a battery is to disconnect. So you unscrew here and then you change out. Make sure that the half moons are lined up, and then you just depress and screw back on. Notice the alarm for the disconnected battery was going off at the same time. So if we had a controller fault and it says to change out the controller, this is the way that you want to do it. So it's easiest way is to turn it over and line up the 2. This is what you'll see once you unlock the actual door here. So it's in the lock position, now it's unlocked. Normally you won't see this button, you'll see this red one. So to change out the controller, what you want to do is you want to change out one of the batteries first. So disconnect one of the batteries and attach it. It's going to alarm. Then you're going to change out the drive line by depressing the button. And go ahead and silence. And now it's starting to run. See how there was little changeover? Then we want to change over the other battery. Silence. Line it up. Screw it on. Now the controller is changed. Now to turn it off, what you want to do is hold this battery button for 5 seconds until it goes off. And there you have changed the controller. for the HeartMate 3. So this is the other style of VAD that you might see. This is the HeartWare model, and you can see a little bit different than the HeartMate 3. So to change out the battery on the HeartWare, it's fairly simple. So what you would do is you would rotate this clip right here, just really quick, pull it off, get a new battery, and then line up the arrow here with the red dot on top, and then just gently push on. Make sure that the pins inside don't get bent and you don't actually force it on. So in the event that the controller needed to be changed out, the easiest way to remember it is the 4 Ps. So it would be pacifier, power, pump, power. So I will demonstrate how to do that now. So in the event of a critical failure and you needed to change out the pump, remember the 4 Ps, it would be pacifier, power, pump, power. So this is the pacifier that is located usually on the spare controller. So you place it on the old controller. You change out one battery, place it on the new one, then you disconnect the drive line, put it in the new one, and disconnect the battery and place it on the new controller. If you did not have that pacifier on the device, that alarm would continue to go off until you found it or you placed it back on the device. This is what the pump for the HeartWare actually looks like inside. Always transport the patient's backup bag with batteries and a second controller with the patient. For VAD-related complications or suspected cardiac or respiratory conditions, transport the patient to the medical facility where the VAD was placed if the patient's clinical condition and time allow. For all other conditions, transport to the closest appropriate emergency department without manipulating the device. Whether you are an ALS or BLS clinician, whenever you are dealing with a VAD patient, there are a few important points to keep in mind. LVAD patients are preload dependent and afterload sensitive. VAD patients require anticoagulants and antiplatelet medications to prevent pump thrombosis so that they are at high risk for life-threatening bleeding. VAD patients have an increased risk of sepsis due to their driveline. Chest compressions must be manual, using hands only, because automated chest compression devices may increase the risk of VAD dislodgement. VAD patients can be cardioverted and defibrillated without any changes or adjustments to their VAD. The delivery of electricity by defibrillation or cardioversion will not affect the functioning of the device. Always ask the VAD patient if they have had any alarms and if their parameters are within their normal range. Early contact with the patient's VAD coordinator is encouraged. The patient's specific program should be contacted if possible, since they know the patient best. If that information is not available, phone numbers for the Maryland hospitals that implant VADs are included in the VAD protocol. If you're an ALS clinician taking care of a VAD patient, you should also initiate cardiac and end-tidal CO2 monitoring, establish an IV or IO access, and obtain a 12-lead EKG. LVAD patients who become hypovolemic may experience suction events, which lead to low blood flow through the device and may trigger ventricular arrhythmias. During these events, the inflow part of the LVAD's pump becomes stuck against the heart wall, which severely limits the flow of blood through the device. If the patient shows signs of hypoperfusion or MAP less than 60 millimeters of mercury due to hypovolemia with a functioning VAD, check for low flow alarms and evaluate the patient's cardiac rhythm. If there is evidence of low flow alarms or ventricular arrhythmias associated with low flow alarms, administer lactated ringers and 250 milliliter fluid boluses to achieve a targeted MAP of 60 millimeters of mercury, as long as there are no signs of pulmonary edema. A maximum of 1 liter of lactated ringers may be given over 15 minutes using a push-pull method of drawing up the fluid and pushing it through the IV. We are including a link to a video so that we can review the push-pull method. Additional IV fluid beyond 1 liter of lactated ringers requires medical consultation. Defibrillate or cardiovert as appropriate for the patient's rhythm. The controller or battery should not be disconnected to deliver electrical therapy. You are dispatched to the residence of a 63-year-old female with altered mental status. She is breathing, but drowsy in response to painful stimulus. She has an LVAD and the low flow alarms are going off. You quickly attach her to the cardiac monitor and find her to be in ventricular tachycardia. The automated blood pressure cuff is reading a map of 55 millimeters of mercury. Your next treatment steps should include administer lactated ringers in 250 ml boluses to achieve a map of 60 millimeters of mercury, as long as there are no signs of pulmonary edema, and cardiovert the patient. Start hands-only CPR as the patient has signs of low perfusion. That's correct. The patient is likely experiencing a suction event and would benefit from IV fluid, lactated ringers along with cardioversion for ventricular tachycardia. Patients with suction events may present with low flow alarms, ventricular arrhythmias, and signs of poor perfusion.
Extraglottic airway devices are a valuable adjunct that allow for ventilation and oxygenation. They are sometimes also referred to as supraglottic airways and include devices such as laryngeal mask airways, also called LMAs, and King LTSDs. In Maryland, the King LTSD has been available for use as an alternative airway device for many years, particularly when attempts at endotracheal tube placement have been unsuccessful. However, recent research has shown that EGAs are useful as primary airway management devices, as well as backup or rescue devices. We should think of EGAs as alternative airway devices instead of rescue devices to be reserved for situations when intubation is unsuccessful. Studies have demonstrated that EGAs should be preferred over endotracheal tubes in some patients, including the pediatric population. Evidence also shows there may be increased cardiac arrest survival with EGAs versus ET tubes in adult patients. With this in mind, the 2022 Maryland protocols expand the use of EGAs for ALS clinicians. Jurisdictions must select a specific EGA device and provide hands-on training if switching from the King LTSD. Let's look at the extraglottic airway device section of the procedures in the 2022 protocols and see what's changed. The first thing you will notice is in the heading itself. Instead of a laryngeal tube airway device, the section is now titled Extraglottic Airway Devices. As you look further down the procedure section, you will see the King LTSD is still there, but 3 supraglottic airway devices have been added as options: LMA, AirQ, and iGel. Commercial and jurisdictional EMS operational programs will have latitude to select one of these 3 devices or keep the King LTSD. Every EMS operational program must carry at least one type of extraglottic airway and sizes appropriate for patients of all ages, from newborn through adult. The next change that you will notice is in the indications for use of EGAs. Rather than simply as a rescue device for when a clinician is unable to place an ET tube, indications are patients without a gag reflex and are unable to maintain their own airway, patients who can't be intubated following the administration of paralytic medications, and pediatric patients EGA is preferred over endotracheal intubation. Contraindications now include only responsive patients with an intact gag reflex and known esophageal disease or ingestion of caustic substances. Since a complete array of sizes is now required to be carried, lack of an appropriately sized device is no longer included as a contraindication. The potential adverse effects and complications have not changed in the new protocol and include: the EGA does not protect against the effects of regurgitation and aspiration. High air pressures may divert gases either to the stomach or to the atmosphere. And a potential complication of the King LTSD airway is inadvertent tracheal intubation. After placement of the King LTSD, perform standard checks for breath sounds and utilize an appropriate end-tidal CO2 monitoring device. The specific procedures for placing the King LTSD, LMA, AirQ, and iGel will not be covered in this video. MarylandEMS has provided didactic training for jurisdictions switching from the King to another device. For initial training or a refresher, we recommend that you watch the Extraglottic airway video. Hands-on training on devices selected by your EMS operational program will be provided locally. Please note that for whichever device you are using, if you are unable to achieve adequate ventilation using the EGA, remove the device and resume BVM ventilation with an OPA or MPA. Then attempt placement again. If you are unable to successfully place the EGA on the second attempt, consider obstructed airway maneuvers, if you haven't already done so, and refer to the cricoid thyrotomy or extraordinary care protocols. In summary, EGAs may now be used as an alternative airway device to provide ventilations and should be your preferred option in pediatric patients. Each EMS operational program may choose from the list of devices, including at least one of the following: King LTSD, LMA, AirQ, or iGel, and sizes appropriate for patients of all ages. You are caring for an unresponsive 3-year-old patient who is in respiratory arrest. The patient has no gag reflex and has profuse oral secretions. You have decided that an advanced airway is needed to secure the patient's airway and provide ventilation and oxygenation. Your preferred device should be an appropriately sized ET tube, an appropriately sized EGA, King LTSD, LMA, AirQ, or iGel. Yes, for pediatric patients, an EGA is preferred over endotracheal tube placement.
Did you ever have trouble remembering your H's and T's during a cardiac arrest? Well, the 2022 protocols will help you deal with this problem while simultaneously clarifying the role of sodium bicarbonate throughout our scope of practice. Sodium bicarbonate has been a mainstay in the cardiac arrest algorithm since the beginning of ALS care in EMS. Recommendations for its use are scattered throughout the H's and T's of the PEA Assistly algorithm as a treatment for suspected acidosis due to prolonged resuscitation attempts, as well as in non-cardiac arrest situations such as drug overdose, acidosis, or hyperkalemia. However, recent research has shown limits to the efficacy of sodium bicarbonate, and therefore it is only recommended in specific situations. The American Heart Association limits the use of sodium bicarbonate to the treatment of specific reversible causes related to hyperkalemia, acidosis, and certain toxins. Recent literature reviews have found no evidence to contradict the AHA guidelines. The situations in which use of sodium bicarbonate is now recommended include documented pre-existing acidosis, cardiac arrest only with a high suspicion of acidosis, hyperkalemia, or sodium channel blocker overdose as a cause of the arrest, hyperkalemia, and sodium channel blocker such as tricyclic antidepressant or phenobarbital overdose. You will also find these recommendations incorporated in the 2022 protocols into ALS pharmacology indications for sodium bicarbonate, as well as throughout the protocols, particularly in the adult PEA asystole algorithm. Another important change you will notice is the requirement for medical consultation for the use of sodium bicarbonate for adult patients has been removed. So how do these changes help us with those pesky H's and T's in the PEA asystole algorithm? Let's take a look at how the PEA asystole algorithm has been modified for the 2022 protocols. In the past, once PEA or asystole were identified, the ALS clinician was advised to consider the possible causes, for example, the H's and T's, and was given a general list of possible therapies and treatments for the various causes. The 2022 protocols direct you to look more closely at your patient's cardiac rhythm and use that information to determine your treatment choices. If your adult patient is in PEA with a narrow QRS less than 0.12 milliseconds, you should consider mechanical causes for the cardiac arrest. These include cardiac tamponade, massive pulmonary embolus, tension pneumothorax, or severe hypotension. Your treatment should include wide open fluids, high-performance CPR, and epinephrine. If you suspect a tension pneumothorax, add needle decompression to your list of treatments. If the PEA has a wide complex QRS, greater than 0.12 milliseconds, consider toxicological or metabolic causes. Wide open fluids, high-performance CPR, and epinephrine will always be included in your treatment, but additional treatment choices will differ based on which toxicological or metabolic cause you suspect. If you suspect hyperkalemia as the cause of the cardiac arrest, it is appropriate to add calcium chloride 1 gram IV push or IO, and sodium bicarbonate 1 milliequivalent per kilogram IV or IO, ensuring to flush the IV between the calcium and bicarb. Your suspicion for hyperkalemia should be higher for patients with a history of kidney disease or known kidney failure, dialysis patients, and patients with presentation concerning for crush injury or crush syndrome. If, on the other hand, you suspect a sodium channel blocker overdose from medications like a tricyclic antidepressant or phenobarbital, or severe metabolic acidosis as the cause of the cardiac arrest, your treatment should be sodium bicarbonate 1 milliequivalent per kilogram IV IO. If your patient is in asystole, you should also consider hypoxic causes. You should ensure that your patient has adequate airway and ventilation, and treat with wide open fluids, high-performance CPR, and epinephrine. If you suspect a tension pneumothorax, also perform a needle decompression. To summarize, every cardiac arrest resuscitation need not end with the administration of sodium bicarbonate. However, please keep in mind that there are cases driven by clinical suspicion and presenting rhythm in which bicarb can be helpful or life-saving. Scenario: you are treating a 65-year-old male patient who is in cardiac arrest secondary to choking on food. You observe asystole on your cardiac monitor and have confirmed this rhythm in multiple leads. High-performance CPR is being performed, and you have already cleared the patient's airway with McGill forceps and intubated him. Tube placement has been confirmed using visualization, auscultation, and capnography. BVM ventilations are being performed with good compliance. You have also already established an IO and are infusing lactated ringers. The resuscitation attempt has been going on for 20 minutes, and you have just given the third 1 milligram IO dose of epinephrine. Is sodium bicarbonate indicated for this patient? A, yes. He may be acidotic due to the extended length of the resuscitation efforts. B, no. This patient is in a systole with hypoxia due to choking as the cause of his cardiac arrest, so sodium bicarbonate is not indicated. Correct. According to the 2022 adult PEA asystole algorithm, sodium bicarbonate is not indicated because the suspected cause of this cardiac arrest is hypoxia rather than acidosis, hyperkalemia, or tricyclic antidepressant phenobarbital overdose. Good job.
You're on scene with an agitated patient who is irrational and presenting with behavior that puts everyone at risk. You have tried calming the patient down without success and have determined that medication prior to attempting transport will be the best option for keeping both you and your patient safe. What should you keep in mind when choosing a medication? Most EMS clinicians would consider the time of onset and risk of adverse effects with a medication as among their greatest concerns. Previously, the options for ALS clinicians treating a patient with moderate agitation consisted of haloperidol or midazolam. In the 2022 Maryland medical protocols, you will find that haloperidol has been replaced with droperidol for the treatment of moderate agitation. Droperidol is an antipsychotic medication with the benefits of a shorter time of onset and reduced need for repeat dosing when compared to haloperidol. Additionally, research has confirmed that at the dose range recommended in the new protocol, droperidol does not cause a significantly longer QT interval than haloperidol. In fact, the two medications have similar prolonging effects on the QT interval, which can lead to higher risk of cardiac dysrhythmias. Patients receiving these medications should be placed on a cardiac monitor as soon as practical. Of note, midazolam is associated with an increased need for repeat dosing, as well as increased incidence of adverse effects, particularly respiratory depression, when compared with droperidol. As you can see, there is no perfect medication for the agitated patient. There is not a medication without adverse effects. Careful medication selection based on the patient's presentation and history is important. It is essential that patients receiving sedative medications be placed in a supine position and on cardiac and respiratory monitoring as soon as practical. As you read the description of the droperidol in the ALS pharmacology section in the 2022 protocol, you will see that it is similar to haloperidol. Both are antipsychotic medications that are indicated for moderate agitation due to a suspected psychiatric emergency such as schizophrenia or medical delirium. Remember that the patient with moderate agitation exhibits behavior that puts the patient or clinician at risk of harm. The onset of action of droperidol is within 10 minutes of IM administration. The potential adverse effects and precautions for droperidol are also the same as those for haloperidol. Dystonic reaction, which is rarely seen in short-term use and can be treated with diphenhydramine, hypotension and tachycardia, torsades de pointes or polymorphic ventricular tachycardia. Patients receiving droperidol should be monitored for cardiac dysrhythmias. Violent patients may require physical restraint while the medication is being administered. Where you will notice some differences between the two drugs is in the contraindications and dosages. Droperidol is contraindicated in children under 13 years of age, pregnancy, Parkinson's disease, CNS depression or acute CNS injury, and severe agitation, as it may worsen an anticholinergic crisis. The dosages for droperidol are for adults, patients 18 to 68 years of age, 2.5 milligrams IM. For patients 69 years of age and older, 1.25 milligrams IM. Pediatric dosing for patients 13 to 18 years of age receive 2.5 milligrams IM. Patients less than 13 years of age, droperidol is contraindicated. For patients of all ages, a medical consult is required for additional doses. That is, all doses after the first dose. Given the infrequent need for sedation in patients between 5 and 12 years of age, medical consult is now required for the administration of midazolam or ketamine. Since the change from haloperidol to droperidol applies to both adult and pediatric patients, you will see this reflected in both the adult and pediatric 2022 agitation treatment protocols. Let's take a quick look at these protocols and highlight the changes. In both the adult and pediatric protocols, agitation is classified as mild, moderate, and severe. We will discuss adult patients first. Moderately agitated patients are still cooperative and making rational decisions. They pose no immediate safety concern for themselves or the clinician. Treatment for these patients includes verbal de-escalation and emotional support. No sedation is indicated. Moderately agitated patients are irrational and exhibiting behavior that puts themselves or EMS clinicians at risk. Sources of the agitation may include medical delirium such as infection, psychiatric emergencies including schizophrenia, drugs or alcohol ingestion, head injuries, and unknown causes. Your choice of medication to sedate the moderately agitated adult patient will be determined by the suspected source of the agitation. For adult patients suspected of having a medical delirium or a psychiatric emergency, administer 2.5 milligrams of droperidol IM. For patients who are 69 years of age and older, cut this dose in half and administer 1.25 milligrams droperidol IM. For all other sources of moderate agitation in the adult patient, including drug or alcohol ingestion, head injury, or unknown or other sources, administer 5 milligrams midazolam IM or IV, and reduce this dose to 2.5 milligrams midazolam for patients who are at least 69 years old. Severely agitated patients are physically violent and present an immediate and imminent threat to themselves and others. The treatment of these patients has not changed in the 2022 protocols. As a reminder, for patients with severe agitation presenting an immediate and imminent danger to themselves or the clinicians, administer 5 milligrams midazolam IM or IV, or 2.5 milligrams for patients 69 years of age and older. Or administer ketamine, either 1 milligram per kilogram IV or IO to a maximum of 100 milligrams, or 4 milligrams per kilogram IM to a maximum single dose of 400 milligrams. Note that ketamine requires a medical consultation except when the patient is presenting an immediate and imminent danger to themselves or the clinicians. Droperidol is contraindicated in severe agitation as it may worsen an anticholinergic crisis. For adult patients, medical consultation is required for ketamine administration, except where there is an immediate and imminent danger to the patient or clinicians. Additional doses beyond the first dose of droperidol, midazolam, and ketamine, administration of diphenhydramine, 25 to 50 milligrams IM or IV, if the ALS clinician suspects that a dystonic reaction has occurred in association with droperidol. For pediatric patients, we treat mild agitation in pediatric patients with verbal de-escalation and emotional support. This is the same as for the adult patient. Treatment of the moderately agitated pediatric patient is determined by their age. For patients less than 5 years of age, no medication is indicated. For patients between 5 and 12 years of age, perform a medical consult for midazolam or ketamine. Of note, medication is needed very infrequently in this age group. For patients 13 to 18 years old, administer 2.5 milligrams of droperidol IM. In cases of severe agitation, when there is immediate and imminent danger to the patient or to the clinicians, and the patient is 13 years to 18 years old, administer ketamine, either 1 milligram per kilogram IV or IO to a maximum dose of 100 milligrams, or 4 milligrams per kilogram IM to a maximum dose of 400 milligrams. As with adults, droperidol is contraindicated for severe agitation as it may worsen an anticholinergic crisis. For pediatric patients, you must consult to administer midazolam or ketamine to patients less than 13 years of age. To administer ketamine for patients 13 to 18 years of age, except when there's an immediate and imminent danger to the patient or the clinicians. For additional doses beyond the first doses of droperidol, midazolam, or ketamine, or to administer diphenhydramine in cases of a suspected dystonic reaction in association with droperidol. Whether your patient is an adult or a child, following sedation, you will need to place the patient in a supine, that is face-up position, initiate cardiac monitoring, continuous end-tidal CO2 monitoring, and pulse oximetry. Obtain a 12-lead EKG and evaluate for a prolonged QTC as soon as practical. Evaluate your patient for trauma. Check blood glucose. Check their temperature and initiate passive cooling measures such as cold packs as appropriate. If your patient is tachycardic or hyperthermic, administer a 20 milliliter per kilogram bolus of lactated ringers, and apply physical restraints as indicated in the physical restraint protocol only when there is immediate and imminent danger to the patient and others. Let's look at a scenario. You're on scene with a 70-year-old male patient who is moderately agitated. Local police officers are on scene with you, and between you, your partner, and the police officers, you have persuaded the patient to get into the back of the ambulance, but you are now unable to control his erratic behavior. The patient is irrational, and his family has told you that he is schizophrenic and has been non-compliant with his medications for several weeks. Since you are unable to get him to stay on the stretcher or even sit down on the bench seat, and he keeps trying to open the doors of the ambulance and threatening violence when you attempt to restrain him, you decide that medication is indicated to effect safe transport. What is the correct dosage of droperidol for this patient? A, 2.5 milligrams, or B, 1.25 milligrams? Yes, 1.25 milligrams is the correct dosage for adults 69 years of age and older. Well done.
When it comes to hemorrhagic shock, tourniquets and wound packing are helpful if the bleeding is external and on a part of the body that can be compressed. But how could we help to stop the bleed in a patient with hemorrhagic shock who is bleeding internally or bleeding in multiple non-compressible areas of the body? Well, first, let's take a step back and briefly discuss what happens to severely injured patients. Trauma patients who suffer extensive tissue damage often develop impairment in their clotting pathways. Coagulopathy, or disordered clotting, increases the patient's risk of death and need for blood transfusions. Until now, EMS clinicians have had only two treatment options in these circumstances: controlling external bleeding and administering fluid boluses for hypotension. The 2022 Maryland Medical Protocols introduced an additional option for patients in hemorrhagic shock due to traumatic injury, called tranexamic acid, also known as TXA. Now, let's take a closer look at this medication and how it works. TXA is an anti-fibrinolytic medication that reduces fibrinolysis, or clot breakdown. It prevents the activation of plasminogen into plasmin. In turn, this reduces the amount of plasmin available to attach to fibrin-rich clots, thus preventing their breakdown. In other words, TXA slows down the process through which clots are broken down, thus allowing them to form more easily. The onset of action of TXA is variable, but it starts to take effect in about 5 to 15 minutes, with a half-life of about 10 hours. Several scientific articles have examined the role of TXA in civilian EMS as well as in the military setting. A 2020 review article compiled data from numerous studies of TXA as a pre-hospital treatment for traumatic hemorrhage. This review considered optimal dosing, routes of administration, timing of administration, safety, and effectiveness. The authors concluded that TXA is both a safe and effective pre-hospital treatment for hemorrhage due to trauma. The findings of this article, among others, serve as the basis for the addition of TXA to our ALS formulary. In the 2022 protocols, you will find recommendations for the use of TXA in the adult shock, hypoperfusion, and adult multiple severe trauma protocols. In both cases, you will see that TXA is indicated for treatment of suspected hemorrhagic shock due to a traumatic mechanism in patients 15 years of age and older. In order to be eligible for TXA, patients must have a systolic blood pressure of less than 90 millimeters of mercury, and the injury must have occurred within the past 1 hour. When TXA is given in this population, patient survival significantly increases. The dosage is 1 gram of TXA in 100 milliliters of an approved diluent, such as normal saline, lactated ringers, or D5W, administered IV or IO over 10 minutes. Clinicians are cautioned to administer TXA slowly via IV or IO over 10 minutes to reduce the risk of hypotension and not delay transport to administer TXA. It is very important to not push the TXA fast as it will cause hypotension. Adverse effects to watch for are hypotension if TXA is given faster than 100 milligrams per minute, and seizures. Contraindications for TXA include patients less than 15 years of age, hypersensitivity or allergy to TXA, known arterial or venous thromboembolism, PE or DVT, or patients more than 1 hour from the time of injury. Let's consider the overall treatment of our hypotensive adult trauma patient and see how TXA fits within our existing treatment algorithm. In reality, these steps should occur very quickly, almost simultaneously, to address pressing life threats during the initial patient assessment. In other words, if you have visible exsanguination, please address this first and check the pulse ox later. Treatment, as in the past, will start with the immediate control of external life-threatening hemorrhage, if present, followed directly by addressing the patient's airway and cervical spine motion restriction. If bleeding is life-threatening at any time or continues despite direct pressure, then attempt wound packing, hemostatic bandages, and/or early tourniquet application as appropriate. Apply spinal motion restriction as appropriate. Remember, the patient with isolated, penetrating neck trauma shouldn't have a C-collar applied unless the airway is definitively controlled. Place an OPA/NPA early, as needed, to establish or maintain a patent airway. Next, we consider breathing and ventilation. Provide ventilatory support and oxygen as needed via an appropriate method for the patient. Maintain pulse oximetry of 94% or greater. Maintain end-tidal CO2 between 35 and 40 millimeters of mercury for any patient with a significant head injury. For a patient with suspected head injury and signs of herniation, consider adjusting ventilations to achieve an end-tidal CO2 of 30 to 35 millimeters of mercury. If there is a suspected tension pneumothorax, perform needle decompression thoracostomy. Circulation with hemorrhage control is where TXA appears in the protocol. Apply direct pressure to areas of external bleeding. If a tourniquet was previously applied, reassess it to ensure that the tourniquet is still in the proper position and controlling the bleeding. Apply pelvic stabilization if indicated. For a patient with systolic blood pressure less than 90 millimeters of mercury or less than 110 millimeters of mercury in patients with a suspected head injury, establish IV or IO access and administer small boluses of lactated ringers to achieve and maintain a systolic blood pressure of greater than or equal to 90 millimeters of mercury or 110 millimeters of mercury in the patient with a suspected head injury. The maximum single bolus is 250 milliliters prior to an additional blood pressure check. Remember that we want to use the minimum amount of fluid necessary to maintain perfusion, and additional fluid boluses beyond 2,000 milliliters require a medical consultation. For patients 15 years of age or older with suspected hemorrhagic shock, systolic BP less than 90 millimeters of mercury, due to trauma, administer 1 gram of TXA in 100 milliliters of an approved diluent, normal saline, lactated ringers, or D5W, IV or IO over 10 minutes if the injury occurred within the past 1 hour. Do not delay transport to initiate TXA. Initiate a second IV for category Alpha and Bravo patients only if it does not delay transport. Treat pain as appropriate per the pain management protocol. You are dispatched to a rural area for a 35-year-old male fall victim. You discover that the patient was sawing a tree when a branch gave way, causing the ladder to fall. He fell to the ground approximately 20 feet. The patient denies loss of consciousness. He is currently alert and oriented. GCS is 15. He tells you that he just fell about 15 minutes ago. He has a complaint of abdominal pain, flank pain, and back spasms. He is diaphoretic and lightheaded. You note bruising development on his flanks, but no evident external bleeding. You initiate spinal motion restriction and obtain vital signs. His initial vitals are as follows. Blood pressure 80/60, heart rate 120 and regular, respiratory rate 22, pulse ox 96% on room air. You initiate an IV with lactated ringers. As you move towards the ambulance, you wonder if this patient qualifies for TXA. Does this patient qualify to receive TXA? Yes, the patient should receive TXA. No, this patient does not qualify for TXA. Correct. This patient has a significant traumatic mechanism with suspected hemorrhagic shock, as evidenced by his exam and systolic blood pressure of 80, and the injury occurred less than 1 hour ago. He will qualify to receive tranexamic acid, TXA, to decrease the risk of ongoing internal hemorrhage. You have determined that the patient should receive TXA. What is the correct dose and route of administration? 1 gram of TXA mixed in a 100 milliliter bag of normal saline, D5W, or lactated ringers, and administered via IV or IO slowly over 10 minutes. 1 gram of TXA mixed in a 100 milliliter bag of normal saline, D5W, or LR, administered via IV or IO at a wide open rate. That's right. You should mix 1 gram of TXA in 100 milliliters of approved diluent, which may be either normal saline, D5W, or LR, and administer this via IV or IO slowly over 10 minutes, 100 milligrams per minute. Faster administration increases the risk of hypotension and seizures.